Hey, good morning. This is Dr. Gonzo, and you're listening to Talking Points. Today, I have another pleasure of presenting and having somebody here on the show, one of our vascular surgeons and colleagues in the vascular program and aortic program, Dr. Mirza Baig. Mirza, thank you so much for being here with us this morning.
Oh, good morning. Thank you very much. It's a pleasure to be here.
Okay, so one of the things before we jump in, the first thing that I want to say is congratulations, a new baby, right? New
Yes.
member of the family.
Yes, thank you very much.
And I'm sure that you woke up early this morning just to talk to me, and you haven't fed the baby yet, right?
Luckily, I don't have to do the feeding.
I'll tell you, when I was a resident, it was so brutal when I had our first baby, because I was doing almost every other night on call, and having to do the evening feed was the most painful thing. Not because I didn't want to do it. It was just because the expectation of having to get woken up again in 2 hours was incredibly painful. But congratulations. Is this your first one or your second one?
No, this is number 5.
Number 5?
Yes.
Dude, I hope you have a lot of money saved. Okay, let's jump into this. So, what I wanted to do today was talk about a particular interest of yours and that is aneurysm care and dissection care. Okay. And several podcasts ago, I had the chance of interviewing my colleague, Jeff Wu, who's also very passionate about ascending aortic aneurysms and ascending aortic dissections. So just to put the listener in perspective, an aneurysm is a dilatation or enlargement of any blood vessel, but in your case, it's the aorta. But it's not the same side of the aorta, or it's not the same. It's not the same side of the aorta which Jeff is interested in. You take care of a completely different side of the aorta. So why don't you tell the listeners exactly what an aneurysm is, and the aneurysms that you take care of, where are they located?
So most aneurysms I take care of are in the abdominal aorta, but I also take care of thoracic aortic aneurysms in the descending thoracic aorta. So that would be past the left subclavian artery. Sometimes they can be, onto the subclavian artery, and we can still take care of them. But the vast majority of them are in the descending thoracic aorta and the abdominal aorta.
Okay, and so what I usually describe to patients when I'm talking about aneurysms is that think about the aorta like a candy cane, right? And so the short end of the candy cane basically is what we call the ascending aorta, because the blood flows from that end through the upper segment of that candy cane and then across and then down to the feet and leg, which is a descending portion. So you basically are a specialist of anything that happens on the long side of that aorta, or that candy cane, right? Or that aorta, correct?
Yes. Yeah. Everything after the arch.
Okay, perfect. And so what causes descending aortic aneurysms?
So there are a number of risk factors. Age is obviously the most important one, because aneurysms are a degenerative disorder most of the time. With advancing age, the incidence of aneurysms goes up. And then there are other factors associated, such as smoking, hypertension, as well as genetics does play a significant role in the development of aneurysms. People with a family history of aneurysms are more likely. There are genetic disorders with problems manufacturing proteins that are involved in the tensile strength of the blood vessels. And so if those proteins aren't working properly, then the aorta starts to weaken, the wall starts to weaken, and people will develop aneurysms at a much earlier age than normal. Most people get their aneurysms, in their later decades of life, in their 60s, 70s, and so on.
Okay, so this is actually a disease that you see a lot on people that are older, but you also see them in the younger ones, and the younger ones are the ones that are typically associated to genetic conditions or predispositions, right?
Absolutely, yes.
Okay, and so how do you usually see that aneurysms present? Do they have symptoms, or are they asymptomatic? In your experience, how do they usually present?
Well, it's a little different between thoracic and abdominal aneurysms. Thoracic aneurysms, because the thoracic aorta is within the rib cage, you can't feel when the person has an enlarged thoracic aorta. So most of these are discovered incidentally, and that's why, they're considered a silent killer, in the sense that most patients don't have symptoms, and when they do have symptoms, it's usually when there's a catastrophic problem, such as a rupture of an aneurysm. So because of the prevalence of imaging nowadays for, practically every complaint.
For everything. I mean, everybody who has a chest pain, everybody who has even a cough, they get now a CT scan, right? And that's usually how we're discovering all these things.
Exactly. So, somebody if you have a large enough aneurysm, you'll see it on a chest X-ray. If not, a CT scan can find even small aneurysms. Now, that's a little different than abdominal aneurysms, even though abdominal aneurysms are also found incidentally. Medicare has a screening program for abdominal aneurysms. So if you're a male smoker that's gets started on Medicare, if you've ever smoked in your life, you qualify for a screening ultrasound of the aorta.
I didn't know that. So nowadays you actually basically can get CAT scan if you
you get a screening ultrasound.
I'm sorry, a screening ultrasound, which actually doesn't have radiation, so it's actually better for the patient. Okay, good.
Basically, a safety profile is there's almost no risk at all from an ultrasound. So an ultrasound can be done when you do your first Medicare physical examination if you've ever been a smoker and you're male. And there's some talk about covering it for women, but the incidence of aortic aneurysms in the abdomen is much higher in men than in women. So even though that seems to be changing, I'm seeing more and more women with aneurysms nowadays. But you can get a screening ultrasound. But besides that, you can actually feel an aneurysm in the abdominal aorta when you do a physical examination. So the primary care doctors can feel when the aortic pulsation appears to be wider than normal. And based on that, they can order an ultrasound on anybody. And that's not a screening ultrasound. That's based on, some abnormality that's detected during examination. So that's covered for everyone. Despite all of that, vast majority of abdominal aneurysms are still found incidentally for whatever reason. And
then basically, so then once they get diagnosed, and they then sort of send them to you. What happened? So tell me, either the risk factors if you're not treated, or what's the natural history of these aneurysms if they go untreated.
So it really depends on how much growth you have. If you have an aneurysm that continues, some aneurysms will grow to a certain size and then they don't grow much at all. If your blood pressure is under control, or stop smoking, and so on. So in that sense, you have to monitor the size of an aneurysm. But the natural history of an aneurysm that continues to enlarge is that once it gets large enough, it will rupture. And that's because the forces on the wall will increase, and there's more tension on the wall the larger the aneurysm is and the higher your blood pressure is. And eventually, if that tension exceeds the strength of the wall, then the wall will break, just like a balloon pops once you overinflate the balloon. So that's basically the end game for an aneurysm. And if it ruptures, the vast majority of those turn out to be fatal. And that's why it's important to detect these aneurysms, to follow them until they're large enough that they need to be fixed.
Okay, so you hit on a good point. Is there a particular size that you see the increase in the aneurysm rupturing? So do you suggest people to get treated if it reaches a particular size?
Yeah, so in terms of size, basically the calculation is really when is the risk of rupture higher than the risks from the repair.
Okay, great point.
So aneurysms can rupture when they're smaller than the typical size at which we repair them.
Right.
However, the incidence or the the odds of that happening are so low that we don't fix thoracic aneurysms till they're about 5.5 to 6 centimeters, because of the risk of surgery itself, whether that's open surgery or stent surgery. They both have risks, even though stent surgery has less risk. So typically, I'll wait till they're 5.5 to 6 centimeters in the thoracic aorta. If it's in the abdominal aorta, it's the same thing. It's about 5.5 centimeters for men. For women, really depending on the size of their native aorta, the part or the size of their normal aorta, I'll fix them sometimes starting at 4.5 centimeters or 5 centimeters. But really, in those situations, I look at their normal aorta. If their normal aorta is 16, 17 millimeters, and they have a 4.5 centimeter aneurysm, I'll probably fix it. If their normal aorta is 2.5 centimeters, I'd probably wait till it's over 5 centimeters to fix it in a woman.
Well, and you hit on the head. I think that the gender disparities have also to do with the size of the person, right? Because let's be honest. If you get LeBron James, who's a beast, right? And his aorta is, X size. His aorta size is probably normal for his size and shape, right? Whereas if you get a 4'11", 65 kilogram or 120 pound wet female that has a 4.5 aorta, that's a different animal, right?
Yeah. I mean, I think it is. And intuitively, it certainly makes sense that it is, because, an aneurysm by definition is when the blood vessel is 1.5 times bigger than the normal size of that blood vessel. So if you've got a 2 centimeter aorta, once it gets to 3 centimeters, the part that gets to 3 centimeters is considered aneurysmal. Now, it doesn't need to be fixed at that size because the wall is still able to handle a lot of stress at that size. But as it gets bigger, and when it gets to about 2.5 times the normal size, which for a 2 centimeter aorta would be about 5 centimeters, then that's when, I start getting concerned that the tensile strength of that wall is, compromised, and the risk of rupture starts to go up.
Right. And then if you have also genetic components, because the other thing that we know is that if you have somebody, a family member that have actually suffered of aneurysms, or you have genetic predisposition of developing a weak aorta, those usually have a little bit more of an urgency to get treated. Or if you have a rapid expansion, right? If they grow really fast in a particular period of time, and usually it's within a year, then those individuals are at higher risk, right?
Yes. So we follow patients yearly with an ultrasound once their aneurysm's detected, or if they have a thoracic aneurysm, which we can't see with ultrasound, we follow them with CT scans. And once they reach the size threshold, we fix them, or they're growing much more rapidly than we like, we'll fix them.
So when do you tell people that they should come in and see you?
So in general, even though we don't fix aneurysms till they're about 5 to 5.5 centimeters, I think anybody that has an aneurysm in the abdomen of greater than 4 centimeters should be seen by a vascular surgeon. And if the primary doctor is not comfortable following it, they can come even earlier. But that's the time to really get plugged into, a vascular clinic, and kind of get educated about the risk factors and what lifestyle modifications the patient can do to decrease the risk of aneurysm growth. They can stop smoking, get their blood pressure under control, basically be on what we call anti-impulse therapy.
Okay.
Which means, the faster your heart rate and the higher your blood pressure, the more your aorta is stretching every day.
Okay.
So if we can keep the heart rate under control, keep the blood pressure under control, that's a lot less wear and tear on the aorta. And that's what I do for patients that come in with smaller aneurysms. I educate them and get them motivated to take care of themselves so we can avoid ever having to repair it, because even though repair is very, very safe nowadays, it's not 100%, and it's always better not to have an operation if possible.
Absolutely. Okay, so tell the listeners, what are the therapies that you have to your disposal if they have a descending or thoracic aneurysm, or if they have an abdominal aneurysm? So how do you treat them? What modes of therapy do you have?
So the vast majority of thoracic aneurysms now are treated with stent grafts. They can still be treated with open surgery, where we basically make an incision between the ribs and open the chest cavity and replace the part of the aorta that's aneurysmal.
Right.
But that operation is performed very infrequently now, because stent graft repair is quite a bit safer, easier on the patient. Even though the long-term results may not be a huge difference, but the key is to survive the surgery first and without any complication. And from that point of view, stent graft surgery is, I think, much better tolerated. Most patients are at an advanced age, and it is much more difficult to tolerate the open operation. So usually we use stent grafts. So what that means is basically we're putting a sleeve inside of the aorta, that the proximal end of the sleeve is in the healthy part of the aorta above the aneurysm, and in the healthy part of the aorta below that aneurysmal segment. And this essentially excludes the blood flow from hitting the walls of the weakened aorta and significantly decreases the chance that it will rupture, which is what we're trying to prevent.
Okay, so we're here with Dr. Mirza Baig, one of our vascular surgeons in the program, and we're talking about aneurysm disease and how we're treating it. Okay, now what you described, Mirza, is basically the thoracic ones, the ones that are in the chest. But the challenge with the abdominal ones have to do with the fact that they have so many branches, right? I mean, it is literally like branches on a tree. How do you treat those? The abdominal ones.
So the vast majority of abdominal aneurysms occur below the renal arteries, which are the last major branches of the aorta before it splits into the iliac arteries, which feed the legs. So at the belly button, the aorta splits. It's like an upside down Y, and the arteries to the legs start at the belly button. So the majority of aneurysms in the abdomen occur below the renal arteries. So we can put a very simple stent graft in the abdominal aorta that sits just below the renal arteries in the healthy segment of the aorta before the aneurysm starts, and then bring that stent graft down into each leg artery so that it looks kind of like a pant.
Uh-huh.
And that works for the vast majority of people. However, the key there is to have enough healthy aorta below the kidneys. Now, there's a fair portion of people that do not have that. They either have maybe a couple of millimeters below the kidney arteries, or their aneurysm actually extends much higher into the part of the aorta that's giving off these major branches. So
what do you do in those cases?
So in those cases, we have a fenestrated stent graft available. What that essentially means is that if your aneurysm comes up to just below the kidney arteries and you have to put a sleeve in that, that sleeve has got to go above the kidney arteries, because the most important aspect of fixing an aneurysm with a stent graft is you have to have an adequate length of aorta in which this stent graft, or which this sleeve, is able to sit and seal off the blood flow from the diseased part of the aorta. So if we have to extend this sleeve above where the arteries to the kidneys come off, or the artery to the gut comes off, now you've got to have a sleeve that's got holes cut out in it to line up with where the artery to the intestines or the artery to the kidneys come off.
Okay.
Now, in people, that everybody's going to have some variation.
Yeah, not everybody's the same. So how do you adjust for that?
Yeah, so these are all custom-made devices. So these fenestrated devices, right now there's only one company in the market that makes these, and so we take a CAT scan. We measure out the distance between the renal arteries and between the superior mesenteric artery, which is the artery to the intestines. We map out where they are on a clock. So if you imagine the aorta is a tube, and on that tube, there are going to be various clock positions at which these blood vessels can come off. They can come off right at 12 o'clock or 1 o'clock or 3 o'clock or 9 o'clock.
Right.
But we've got to figure out where those blood vessels are coming off, what the distances between them are in the length of the tube. And once we figure that out, we can order a stent graft that's got cutouts made in those spots. And then when we go to do the surgery, we essentially introduce the device into the abdomen, into the abdominal aorta. We do a picture to see where those blood vessels are coming off and kind of confirm where they are. And then we line up the device with the origins of those blood vessels so that the holes are lining up with them. And then we open the device. We put wires through each of those holes and into each branch that we're trying to save. And once that's all secure, we put stents through those holes into each branch, which sort of locks the hole in place and also prevents blood from getting through the hole and into the aneurysm. And that's a very effective operation and has very good long-term results. And the vast majority of patients, go home within a day or two instead of when we had to do those surgeries, open, which would require, and we still do some open, if you have a very young, healthy person, sometimes it's better to do open because these endovascular repairs require lifelong follow-up. You've got a metal cage with fabric that's put in, which is what these stents are made out of. And there's always a risk of fatigue in those materials over time because they're, in a pulsating blood vessel. And so we follow those over time to make sure there are no long-term, complications. And even though our data shows that the long-term complications are low, there are enough that it's important to follow these patients lifelong.
Well, let me tell you, boy, I'm glad that there's somebody like you who specializes in this, because it sounds like there's got to be a lot of schooling and education to do some of these things. I certainly don't have the breadth of experience that you have, but I'm really glad that we have somebody like you on the program. So let me ask you a question. So you talked about, it sounds like there's a lot of planning when it comes to some of these aneurysms. But there are times that you're faced with patients that come in with a rupture or what we call a dissection, which is basically a split in the aorta, and the splits can start all the way up in the thoracic portion of the aorta and go all the way down. How different, and tell the listeners how different that is when you compare those to a planned aneurysm, when somebody comes in with a split aorta or a ruptured aorta. How much different in terms of how the patient is, and his overall condition and the situation that you're faced with?
So an aortic dissection, which, as you said, is a split in the layers of the wall of the aorta so that blood is not just flowing in the actual lumen or channel of the aorta where it's supposed to flow, but it's flowing between the layers of the wall. It's significantly different than a degenerative aneurysm in the sense of you can have an acute, blockage of arteries as a result of that dissection. People tend to have, significant pain in the back of their upper chest when this occurs, and most of the time it's associated with high blood pressure. So the most important thing in those situations is to get the blood pressure under control so that you don't get a rapid expansion of this dissection, which can then turn into what we call a dissecting aneurysm.
But usually when they present, a lot of people are really sick, aren't they?
They can be most of the time. If it's an ascending dissection, those patients, are really sick, and that's what Dr. Wu, and you deal with all of the time. For descending thoracic dissections, most of the time patients come in with pain. Now, if that dissection goes and interferes with blood flow to the branches of the aorta, that's when those patients get really sick. So
yeah, and I would just want to work a little bit on that point, because the reality about it is that depending on where it tears, the split may block off the blood supply of everything that goes downstream from that tear, right? That's where we call a flap that basically can cause, obstruction of blood going down into the different organs, right? That's how they get sick.
Yeah, so these dissections can be classified as uncomplicated or complicated. So
Good,
uncomplicated is when you have a tear, it causes pain, and it needs to be taken care. The problem needs to be taken care of, but not necessarily have the dissection repaired in the immediate setting, because it's uncomplicated. It's only causing pain, and if you get the blood pressure down, a lot of times the pain goes away. Now, when you have a complicated dissection, what that means is that, one, either the pain is not going away even when you control the blood pressure, because the aorta is dilating up where the tear is, or there's been blockage to the branches of the aorta, such as a blockage of the gut artery.
Yep.
If that tear sort of goes in such a way, and it's not something that anybody can control, it's just a sort of a random event, in a sense, that blood, once it gets between the layers of the artery, starts to spiral down the artery, just like you said, like a candy cane has those red and white stripes. Essentially, the blood spirals down that artery, and as it's coming down, if it starts to go into either the branches of the artery or blocks off the flow in the main channel of the artery in such a way that you don't get blood flow to the gut or to the kidneys or to the legs, then those are a major emergency, because if you don't get blood flow to the gut for a few hours, the gut will die, and that's a fatal event. If you don't get blood flow to the legs for 5 to 6 hours, the leg
and you can lose a leg.
Yeah, well, you can even lose your life, because all the muscle will start dying. You go into kidney failure and lots of things. But yeah, the people lose their leg if you don't restore the blood flow within a few hours, or they'll have permanent, neurological damage if you get to even if you're able to save the leg, because you weren't able to get to it in time, and the nerves died before the muscle itself died.
Okay, so that's a really good point. Let me ask you this: so, all things being equal, right? You have somebody that you're able to treat effectively. What are the risks of the therapy of those stents? Are there any problems associated to them that you have to tell patients? Well, there's always, and again, we're doing these therapies because we know the risks associated to these are so small, or comparatively smaller than if you don't do anything. So what are the risks associated to the stent therapy?
So it really depends on what you're treating. So if you're treating a dissection, ideally, you don't want to treat a dissection in the first 48 hours after the injuries occurred to the aorta, because the aorta in that state...
That's in the descending. Let's qualify that, because the ascending happens...
Oh, yeah, those are surgical emergencies.
You got to go right there and then, but the descending are very different. Go ahead.
Yes. Yeah, descending dissections, if you can medically manage them initially, that's ideal, because when they first occur, the aorta is very, for lack of a better word, irritated and fragile, and putting stents in that situation can actually create a tear that then goes up into the ascending aorta.
Right.
So that's the biggest risk associated with the repairing dissections with a stent. However, once that dissection is sort of settled out, later on, you can go in there and put a stent graft that essentially covers the tear, so that you put the stent graft in the healthier part of the aorta. Most of these tears occur about 1 centimeter or 2 past where the left arm artery or the left subclavian artery originates.
Right.
So if you put a stent graft all the way up to that left subclavian artery, you can cover the entry of the blood into the wall of the aneurysm, wall of the dissection, so you can essentially cure that dissection to a certain extent. Now, there will be tears further down once somebody gets it, but if you cover that entry tear, you can essentially resolve a good portion of these dissections so that they don't develop into aneurysms later on.
Okay, so then let me divide this so the listeners can actually understand this also. So if I were to ask you if somebody shows up, that's not with the dissection, but with an aneurysm, so just basically the enlargement of the aorta. If you were to tell them, or if they were to ask you, Dr. Baig, what are the 3 most common complications that could occur from a stent graft if we put a stent in the thoracic aorta? And what are the 3 more common complications that occur or you could predict that happen if we put in stents in the abdominal aorta? So start with the 3 more common complications that would occur that are recorded or reported in the literature on stents in the thoracic aorta.
So the most common complication are really related to getting the stent up into the thoracic aorta. So because we usually go through the groin, and in some people those arteries can be very small, one problem that can occur is that you will get injury to the artery from the groin up, trying to get the device up there.
Okay, so that's one of the more common ones. Okay, give me 2 other ones in the thoracic aorta.
So another one is the possibility of creating a tear going upwards, but that's very uncommon. But a little bit more common, but still very low percentage, is the risk of decreasing the circulation to the spinal cord.
Okay, and that results in what?
And that results in potential paralysis. It could result in paralysis, usually from about the belly button down. You become weak in your legs and you lose the ability to control your bowels as a result of nerves in your spinal cord dying because of decreased blood flow.
And it's important for the listener to know that those things are very difficult to predict, although uncommon, right? I mean, there are some anatomical things that you can look at and say, well, there's a chance of this, there's a chance of that, but still, it's not 100%, right? I mean, there's still a very small chance, but there is a chance that could happen, right?
Yes, so that's always going to be a risk, but it's associated. The more you have to cover, the more of the aorta between the, past the subclavian artery that you have to cover, the higher that risk is going to be.
Okay, and then let's move on to the abdominal one. So tell me 2 or 3 complications, because the abdominal, again, different location of the body. It's below the kidneys, and we talked about what happens if you have to go above the kidneys. But how about the abdominal one? Risk factors, I guess the first one is going to be the same thing, access point, where you're putting in the catheter in the groin, right?
Yeah, you can have access-related complications. So where you put it in, you have trouble getting the device up. You can get injuries to the artery. Now, in terms of spinal cord problems below in the abdominal aorta, that's very, very uncommon. I would say probably less than 0.1%. I mean, it's very, very uncommon. So I normally don't even bring that point up in that discussion because it's so uncommon.
Right.
So the risks in the abdominal aorta are oftentimes there's clot within the aneurysm. So there's some risk that you can break some clot off and it'll go somewhere down the legs. That's also pretty uncommon.
And that's one important point, because these aneurysms serve as a sac, right? And what gets formed in that sac is basically clot or atherosclerosis that basically fills it up. And while blood goes in the middle of that sac, on the sidewalls, usually there's atherosclerosis.
You've got chronic
clot, right?
Yeah, you've got chronic thrombus that's sort of developed more so to kind of when blood becomes stagnant in those sort of baggy areas of the blood vessel, then it starts to, laminate or starts to line the wall with thrombus. It's usually fairly smooth. and the risk of knocking it off with wires and the device is relatively low, but it's a possibility. But the biggest risk actually with stent grafts in the abdominal aorta is related to whether you did a good repair or not. If somebody doesn't have a long enough segment of healthy aorta below the kidneys, and you try to put a stent graft in there anyway, then those are the patients that tend to have complications because the stent graft doesn't sit properly,
Right.
and blood still leaks around it and goes into the aneurysm. And that becomes a much more difficult problem to solve than if you just did it right in the first place, which is to put the stent graft all the way up into.
And I'm glad you raised that point, because this is a common term that the listeners must understand that we talk about in medicine. It's called an endoleak, right?
Yes. So that's it's a scary word for a lot of patients because the word leak is.
You don't want to have a leak of any type when you actually have an aneurysm repaired. I get.
Yeah. So, when people hear leak, they get really worried. But the reason it's called an endoleak, it means that the blood is not leaking outside of the aorta, but leaking into the aneurysm itself around the stent that you have. Now, those leaks are classified in different types depending on where they're coming from. The worst type is if the stent is not sitting in the aorta properly and the leak is coming directly from the aorta above the stent and into the aneurysm, which usually makes the aneurysm fully pressurized and defeats the purpose of the repair. Other types of leaks there are branches of the aorta, small branches of the aorta coming off where the aneurysm is. So because the aorta or the blood vessels are sort of like a very complex traffic system, you have multiple ways to get off the freeway and get on the freeway. You can have blood coming backwards, essentially, in one of these branches and going into the aorta instead of going from the aorta into those small branches. Those types of leaks don't tend to be, they tend to be much more common, but they don't tend to be as worrisome as the first type of leak that I mentioned. And they need to be followed and treated usually only if the aneurysm is continuing to grow.
So you're you're listening to Dr. Mirza Baig here, vascular surgeon in Irving. Tell the listeners what's the recovery from these stent procedures, and what after they get over the procedure, what's the follow-up?
So the vast majority of patients that have even especially the abdominal aneurysm repair, go home the next day. A lot of times we're able to do these what we call percutaneously, which means that we don't actually make a large incision in the groin. We use a needle to go through the skin and enter the artery and then sort of dilate up that tract to get our device up there. And you barely even need a stitch to close that puncture site when you're done. So in terms of pain and recovery, if the stent graft is placed properly, the recovery is very quick, and most people, even in an advanced age, go home the next day. They're able to walk, 6 to 8 hours after the surgery and eat and everything, and then they go home the next day.
That's amazing. I mean, compared to back in the day when they actually had to stay in the hospital for a week or 10 days because none of these things worked.
Yeah, and especially compared to open surgery where, most patients are in the hospital 5 to 7 days. And the risks, like I said, of this surgery are acutely, at least in the short time, much lower than with open surgery. If you make it through the open surgery and get out of the hospital okay, then you do just as well as people who had stents long term. But the key is to get out of the hospital, with no complications.
So what's the follow-up? What do you have patients follow up afterwards?
So for both thoracic and abdominal aneurysms, we follow up with CT scans. So initially, there's usually a 1-month follow-up CT scan. Then depending on how things look, I'll do either a 3-month or 6-month scan, depending on how complex the aneurysm was or how difficult the repair was. And then it's 1 year after that. Now, for the abdominal aorta, if everything looks perfect, there's no leaks, everything looks great, we can then switch from CAT scans to ultrasound, since
Right.
with ultrasound, we can see the aneurysm, we can measure the size, we can see if it's growing, we can see if there's good flow through those stents, and see if there's any blood flowing in the aneurysms. So we can switch to ultrasound if needed. In the chest, however, for the thoracic aorta, you essentially have to do yearly CT scans and make sure everything's good. After 5 years, if everything looks great, you can probably switch to every 2 years so that you don't get a lot of unnecessary radiation if everything's looking fine. But you do need lifelong follow-up for these stent grafts.
Listen, Mirza, this has been such a really good presentation and discussion about how to manage these aneurysms, dissections, and information on stents. So if listeners that are right now listening to the show, how do they get a hold of you?
I have an office in Irving, Texas, and that's where I do the vast majority of my surgeries and see patients. My office number is 469-800-1380. My email, I can give my email address.
Go ahead.
If they're interested. My email address is Mirza, Mirza, .baig, BAIG, at bswhealth.org. If you have questions about treatment of aneurysmal disease, feel free to email me at that address.
Perfect. Well, Mirza, thank you so much for being today here in the show. I know that a lot of listeners are going to enjoy, listening and learning about aneurysm disease, dissections, and how to manage these. And you've been great. Keep up the great work there in Irving, and we'll be talking soon. We typically talk about once a week when we have a problem, right?
Yes. Yeah. So call me anytime.
We will. Okay, my friend. Well, listen.
It's my pleasure. Thank you.
Thank you for being on the show. For those listening, thank you for tuning into to Talking Points. This is Gonzo Gonzalez signing off for the show. Talk to you guys next week.